Namaste, Amisha over here. I JV'N Gaurav from the Faculty of Femur AP and Diagnostic in the Department of Diagnostic and Community Health in the discipline Radiology from JV'N Women's University. Today we are discussing a session that is important or useful session for application of radiation imaging technique or radiographic technique and general radiation physics. So today's session will be helpful for the student to know or understand the general radiation physics or production of X-rays or any type of particles or rays or the positioning of patient. Okay. Namaste. Myself JV'N Gaurav. In today's session, we will discuss about the femur AP lateral view, that is in radiographic technique of the whole body and BScRT second semester. Let me discuss about the AP view of the femur. It is a part of the series like femur AP lateral. Okay, it including hip and knee joint series, including hip joint. Femur includes hip and knee joint due to limitation of the image. Due to limitation of the image detector, these projections are often performed in 2 images per view to ensure inclusion of both knee and hip joint. Okay. When we are taking the AP view of femur, then there are 2 separate views. One view that covers the knee joint with the femur, or one view for cover or include the hip joint with femur. Okay. Indications. This will demonstrate the femur in its natural anatomical position, means supine position, allowing for assessment of the suspected dislocation, fracture, localizing foreign body, and osteomyelitis with the long bone. Depending on department, this view can be crucial for orthopedic surgeon to determine the length of the femur for prosthetic purposes or prosthetic leg. Okay. So through this view, we can evaluate the dislocation, fracture, localizing foreign body, and osteomyelitis. Patient position. Patient is in supine position. Lower limb are internally rotated. 15 to 25 degrees from the hip. It is not performed. The angle is not made in the case of fracture suspected. If acquiring the entire femur in one image, place the detector in a diagonal position parallel with the femur. Okay. So the next is the technical or exposure factor. It is the anterior AP projection centering point for one image mid femur region. Mid shaft हो सकती है mid femur region. For 2 images, proximal femur, distal femur. Place detector to include anatomy from AS to mid femoral shaft. Distal femur, place detector to include anatomy from mid femoral shaft to knee joint. This is a distal femur. To ensure overlap of anatomy, a physical side marker can be positioned at mid femur region. Okay. So collimation laterally to skill margin, superior to AS, inferior to proximal third of the tibia fibula. Orientation should be portrait. Detector size 30 by 30 centimeter, means 14 by 17 inches. Exposure factors 60 to 70 kbp. MAS is in the range of 12 to 20. SID, source to image receptor distance, means MAS is in the range of 8 to 16. Or SID 100 centimeter. Grid, yes, it is used in this view. image technical evaluation or radiographic appearance. Entirety of the femur should be seen on the image with the long axis of the femur running long axis of the femur running parallel to the long axis of the image. Okay, so greater trochanter should be seen in profile, signifying adequate internal rotation of the limb. So we can see greater trochanter. ओके, और इससे क्या पता लगेगा, इंटरनल रोटेशन ऑफ द लिम्ब को पता लगाएंगे. प्रैक्टिकल पॉइंट्स क्या रहेंगे, इंटरनल रोटेशन कैन बी असिस्टेड विद द यूज ऑफ सैंडविच ओवर द lateral edge of the patient's feet. Okay, next is the femur lateral view. The lateral femur view is the part of the series of the femur, it including the hip and knee joint. Due to the limitation of the image, these projections are often performed in two images, with knee or with hip. Indications: this view demonstrates the femur in the orthogonal position to AP view. This allows assessment of suspected dislocation, fracture, localized in foreign body, osteomyelitis with the long bone as a femur AP view. Patient positioning: the patient is rolled at least 45 degrees onto the side of the interest. Okay, the unaffected leg is bent to stabilize the patient position. Foot firm on the bed to ensure stability. If acquiring the entire femur in one image, place the detector in a diagonal position parallel with the femur. Technical factors: center point for one image, mid-femur region as well as the AP view. For two images, proximal distal femur as like AP view. Okay, collimation laterally to skin margin, superior to ASIS, inferior to proximal third of the tibia fibula. Okay, orientation should be portrait. Detector size 14 by 17 inches. Exposure factor same as 60 to 70 kVp, but MES is in the range of 12 to 20. SID 100 centimeter. Grid, yes, grid is used because the higher exposure factors are used in this way. Image technical evaluation: greater lesser trochanter should be superimposed by the femoral neck, or a small part of the lesser trochanter is visible medially. Anterior and posterior margin of the femoral condyle should be superimposed. Okay, so in this session we have discussed about the femur AP in lateral positioning, exposure factor, and what we can evaluate after the taking the image. Okay, thank you. The session is over. Okay. Namaste. In this session we will discuss about the foot AP and oblique view in the radiographic technique full body for BScRT technique. The AP view or dorsoplantar view is a part of the series of the foot. Okay, of phalanges, metatarsal or tarsal bones. Indications: this view demonstrated the location and extent of the fracture in the foot, joint space abnormality, soft tissue effusion, and is the frontal view for the examination of foreign body. So the patient position: the patient may be supine or upright depending on comfort. The affected leg must be flexed. Enough that the plantar aspect of the foot is resting on the image receptor. Okay, technical factor of exposure factor: it is the AP projection centering point actually centered to the base of the third metatarsal. The beam must be angled approximately 10 degrees posteriorly towards the calcaneum to mimic the arch of the foot. This may change if the arch is high or flat. Collimation lateral to include the skin margin, anterior to include the skin margin of the distal phalanges, posterior to include the margin of the calcaneum. Orientation should be portrait. Detector size 8 by 10 inches. Or exposure factor 45 to 55 kVp or or MAS is in the range of 4 to 8 MAS. SIG 100 centimeter, grade no, there is no grade is because the exposure is less. What we can evaluate through this view or radiographic appearance, first metatarsal has even concavity. The spaces between the second to fifth metatarsal are equal, here the cases of overlapping. Intertarsal space between the medial and intermediate uniform should be open. Okay. The basis, practical point, the basis of the metatarsal and the tarsal bone are the most reliable location indicator on the view. Okay. The next is the oblique position. Is a part of the series of the foot. Indication this view demonstrates the location and extent of fracture. This view demonstrates the location and extent of fracture. This view demonstrates the location and extent of fracture in the foot and joint spaces abnormality as like AP view. It is also used in the determination of the osteomyelitis and examination of the foreign bodies. Patient position. The patient may be supine or upright depending on comfort. The affected leg must be flexed enough that the plantar aspect of the foot is resting on the image receptor. Image receptor resting on the image receptor like this is the image receptor of this is the foot. The foot is medially rotated. The foot is medially rotated until the plantar surface sits at the 45-degree angle to the image receptor. Okay, like this. Okay, this is the image receptor. Then foot is 45-degree from this. Okay, exposure factor. The AP oblique position, centering point X-ray being centered to the base of the third metatarsal. The beam will be perpendicular to the image receptor. Collimation lateral to the skin margin, anterior to the skin margin of the distal phalanges, posterior to the skin margin of the calcaneum. Orientation should be portrait and detector size is 8 by 10 kg. Exposure factor 45 to 55 kg or MAS is in the range of 44 to 8 MAS. SIG, source to image receptor distance, should be 100 cm or grid. No, grid is not used in this. What we can evaluate or image technical evaluation, a superimposition is evident at the bases of the first and second metatarsal. There is no superimposition of the third to fifth metatarsal. Base of the fifth metatarsal is free of superimposition from any fracture. Tarsal sinus is available, is visible. Tarsal sinus is visible. Joint spaces around the cuboid are open and equal. Cuboid is free of superimposition. Practical point. The metatarsal and tarsal bone are the most reliable rotation indicator. So the foot is over rotated, the base of the fifth metatarsal will be superimposed by the tubercle of the fourth metatarsal. इसमें क्या होगा व्यू में फर्स्ट एंड सेकंड होंगे सुपरइम्पोज होंगे मेटाटार्सल, थर्ड और फिफ्थ होंगे मेटाटार्सल सुपरइम्पोज नहीं होंगे. और ये किसी वजह से होता है बेस ऑफ फिफ्थ मेटाटार्सल जो होगा फ्री होगा सुपरइम्पोजिशन से और टार्सल साइनस विजिबल होंगे और जॉइंट स्पेस पे अपन अच्छे से देख पाएंगे, ओपन होंगे. ठीक है. क्यूबॉइड जो होगी, क्यूबॉइड जो टार्सल होगी वो क्या होगी, फ्री होगी किससे, सुपरइम्पोजिशन. ओके, थैंक यू. द सेशन इज ओवर. Thank you. Namaste. In today's session, we will discuss about the sacroiliac joint (SI joint) in radiographic technique of full body for BScRT second and student. So, SI joint, the AP sacrum projection is part of the sacroiliac series that includes an oblique projection of the joint on both sides. Although usually taken as an AP projection, it can also be taken PA with a reverse caudal central raise angulation of 30 to 35 degrees when patient cannot assume supine position. So when patient is not comfortable, then when we can take PA view with 30 to 35 degree angulation at equal distance from the imaging table to prevent a rotation. Exposure factor, it is the epiview central point midline 5 cm below central ray midline central lateral part midline 5 cm below the level of anterior superior iliac spine 4 cm above the symphysis pubis. Central level cephalad angle of 30 to 35 degrees. Collimation laterally to include both SI superiorly or inferiorly to include the entire sacrum. Orientation should be portrait. Detector size 8 by 10 inches, or the exposure factor is 60 to 70 kVt, or MAS is in the range of 20 to 30. SIT 100 centimeter grid, yes, grid is used in this view of rotation. Image technical evaluation, the acroiliac joint are demonstrated closed. The sacrum should not be foreshortened, and inferior segment of the sacrum should be overlapped over the symphysis pubis. The mid-sagittal plane of the sacrum should be aligned with the symphysis pubis to ensure no rotation. Should be aligned with the symphysis pubis. Okay? To ensure no rotation. Thank you. In this session, we have discussed about the SI joint. Okay, SI AP. Thank you. Thank you. The session is over. I think you are satisfied with this session. If you have any query, then put it into the comment box. I will resolve it later. Thank you. This session is over. The session is powered by digital version 2.0. JV'N Namaste.